Hello again. For this talk, I'm going to be reviewing the best of DDW 2021, focusing in on IBS. Again, in my disclosures, as you saw earlier. And if you'll bear with me for a minute, I'm going to shamelessly talk about a couple studies that we conducted in the past, and then review how it highlights into DDW 2021. So shown on the left-hand side was a study we did about a decade ago where we gave a group of IBS patients a placebo and told them it was a placebo and compared it to no treatment. And as you can see in the bottom with the IBS score, after a 3-week period, there was a significant difference. Shown on the right-hand slide is a more recent study that we have just published in Pain in 2021. And we compared, again, open label placebo, and this time we compared it to double-blind placebo, and they either got double-blind placebo or peppermint oil, didn't know which one they were getting, versus a no treatment or no pill control. What was notable here is that there was, again, a significant difference between placebo, double-blind or open label, and no pill control, but there was no significant difference between open label and double-blind placebo for the IBS-SS endpoint, or as you can see, for adequate relief. This proposes a number of different potential mechanisms whereby placebo may be working. We suspect that they work by different mechanisms, whether it's double-blind or open labels. Really intriguing data. So the first paper I want to present looks at the data that we used in that double-blind versus open label. And what we did was we looked at the side effects, these non-specific symptoms that patients report, that we asked at the beginning of the trial and throughout the trial. And these were the typical symptoms, and you probably can't read on the bottom left-hand side, but typical typical symptoms, whether it be neurological, musculoskeletal, et cetera, that you would see in a clinical trial. We all know that when you open a package insert that headaches, fatigue, myalgias, throat pain, a variety of different things are reported, and you have to sift through and look to see if it really is different between the placebo and the treatment group. And so what we did here is we asked, did those symptoms exist at baseline? And what you can see in the graph on the upper right was in the dark blue is the baseline for double-blind, which is the mint or placebo or treatment as usual. Even look at treatment as usual. There's a large number of symptoms that were present at baseline. And even in treatment as usual, there was a significant difference between the baseline and the 6 weeks later in this overall symptom burden of these treatments, these typical non-specific symptoms. And these were not GI symptoms because we wanted to keep it away because they were IBS patients. So really what we suggest is that non-specific symptoms are common and they are more severe at baseline. And really, we probably should be assessing adverse events differently. We should be asking whether they exist at baseline because many of those side effects that are reported already exist in these studies. Now, I've already emphasized to you earlier about the dietary considerations in IBS. We talked about some traditional IBS diets, the general recommendations, low FODMAP and gluten-free. There were several papers I just want to highlight by DDW that looked at diet in IBS, and I think it's worth spending a few minutes going through it. Before we do, I just want to review for you the data that exists on a gluten-free diet in IBS. Shown on the right-hand side is a meta-analysis of 2 trials with a gluten-free diet. And you can see overall, it still crosses 1, suggesting that it may not be that significant with it. These are relatively small studies done outside of the United States. Shown on the left-hand slide is a study done by Mike Camilleri's group, which randomized patients to gluten-free or gluten-containing diet. These were IBS patients that had not been exposed to diets before. And as you can see, if you look at stool form or ease of passage or frequency, there is a small difference in frequency, but there's really no significant difference in the other symptoms associated with a gluten-free diet in patients with IBS. There was a subset of patients that tended to have the gene for celiac that may have shown a greater effect, but again, relatively small overall. And in general, the recommendation is that there's not enough evidence to recommend a gluten-free diet to reduce IBS symptoms. Well, DDW this year, there was a group from Sweden that studied a low FODMAP and gluten gluten and a placebo diet in a group of IBS patients, 110 IBS patients. And what they did in this study was they took patients and they randomized them, as you can see on the upper left, to 1 week of either FODMAP, gluten or placebo. So they had not low FODMAP, but a high FODMAP or high gluten, and showing the doses on the bottom left, 50 grams versus 17.3 grams of gluten and the specific types of FODMAPs that were given to patients. And they compared the symptoms during these various periods of time. And what you see on the right-hand side is that when they looked at the average score, this is the IBSSS for in abdominal distension on the right hand, which is a component of the IBSSS, that there was a small but significant increase in symptoms when you gave a group of IBS patients a high FODMAP diet. Again, this is about a 50% higher FODMAP than they received in a typical Swedish diet. Again, a small but significant difference. What's notable here, though, is that gluten for all of the symptoms was no different than placebo. So the overall conclusions were there was a modest symptom increase with FODMAPs, but not an increase with gluten. This is similar to what we've seen in other, the general recommendations from the ACG that there really is not enough evidence to suggest a gluten-free diet for the treatment of IBS. So this concurs with that. We've already gone through what a FODMAP is. I won't do that. And I've already highlighted for you earlier the differential effects of FODMAPs within the GI tract shown by Robin Spiller's group. And I alluded to the various phases of the low FODMAP diet, the elimination phases where all of the trials all the data comes from, but there's also these other two phases. We hopefully will see more data in the future with it. This just emphasizes some of the data, that's the individual studies that were done, the original study, the low FODMAP versus typical Australian, low FODMAP versus a traditional IBS diet, and the low FODMAP versus the modified NICE diet, showing, again, no significant difference in adequate relief or the composite, but individual pain and bloating was better with it. So when you look at the meta-analyses for it, there's an overall improvement, but again, the types of comparators do differ, and the overall quality is relatively low. We've already talked about some of the mechanisms of the low FODMAP diet, and I just want to emphasize again, and the reason I'm going back to this is to show you on the bottom right-hand side that we're really looking at different mechanisms. I alluded to some of the food-related mechanisms, but I want to focus in on the low FODMAP mechanisms because this comes back to DDW. A minute. Now, first of all, just to go back in time, Chung Ouyang's group looked at in an animal model the effect of giving a high FODMAP diet. And you can see in the bottom left-hand side, the endotoxins or LPS was higher in the animals that received the high FODMAP diet. And also the TER, which measures permeability, as well as on the right-hand side, EMG, which is hypersensitivity, all either decreased in regard to permeability, increase in permeability in the middle, or increase in hypersensitivity, and exposed to a high FODMAP diet. Now, coming to DDW, Prashant Singh, who's really a rising star in the IBS world, because he was one of our fellows, not that long ago, now working with Chung Ouyang's group, published this paper. And he, on the left-hand side, you can see the work he did with the rodent model, took what was done earlier and expanded it further to show that really most of these effects are through mast cell recruitment and activation. And he was able to show this because when he had a mast cell deficient animal, that they did not get these effects on permeability and hypersensitivity with it. Then he took it another step further and looked at the effects of a low FODMAP diet in IBS, and that's what's shown on the right-hand side. Top right, you can see the effects in IBS-D patients, both on barrier function, mast cell activation, and fecal LPS or endotoxin levels, again, all affected by the low FODMAP diet. And finally, he was able to show that in an animal model that was deficient of TLR4, that when you infuse the supernatant of IBS-D patients, that really you had an increased amount of histamine, which means mast cell release, as shown on the graph on the right-hand side. But when you gave it to an IBS-D patients that TLR4 deficient, they did not get this effect. So again, he shows that here's the mechanism via mast cells whereby a FODMAP may affect GI symptoms. So really intriguing and really interesting data. We know the restrictions of the low FODMAP diet, that it's very restrictive, difficult to follow. There may be some effects on microbiota, et cetera. So the question that comes up is, does the low FODMAP diet need to be so restrictive? And here there are two interesting studies presented at DDW to look at that question. Bill Che's group with Shanti looked at the effects of a low FODMAP diet in various components of the low FODMAP diet. So as shown in the left, right, after a screening period, patients were given open label low FODMAP diet. The vast majority of these patients responded to it. And then they re-challenged them based on 5 different sequences over 7 days with a 7-day washout period for that. You can see the different foods that were given. In this case, fructose, lactose, sorbitol, and FOS was given as well. Shown on the right-hand side is the results for the abdominal pain with it. You see baseline 5.8, open, once they got open label, low FODMAP down to 2.8, stayed relatively low, 2.8 for lactose, fructose, polyols, but not for fructans and galactans, where there was a small but statistically significant increase. So this suggests that there may be components of the FODMAP, i.e. fructan and galactan in this study, that may induce more of the symptoms than some of the other type of foods. Of course, it will be individualized from patient to patient. The second study from Jan Tak's group in Belgium did a similar type study, but again, design is slightly different. They gave patients with IBS a restrictive diet and then reintroduced, and this is over a 12-week period, various types of FODMAPs were given to them, but this was a different design. It had all within 1 week. They gave FODMAPs for a short period of time and then did for 3 days they had regular foods, and then 4 days for this higher FODMAP diet. So a little bit different. And what they showed was that, again, this is with IBSSS on the graph. You can see that with the average restricted diet, the low FODMAP diet, is a significant decrease, but no significant increase was seen with glucose, which was their control, lactose, just a small, but not statistically. But here for mannitol and fructans, you're seeing a significant increase. The dosing is going to be a little bit different of the foods was not reported, so we don't know the exact amount was given. But I think the take-home point here is that fructans is coming up in both studies. In this case, mannitol was also given. We don't know the exact dose. I think, again, the take-home point here is that not all FODMAPs are created equal, and at least both of these studies, fructans is coming out as being a potential culprit. Let's move on to talk about an interesting area of the sucrase isomaltase deficiency. We know that these sucrase and isomaltase are synthesized together. They are cleaved once they get to the duodenum. So oftentimes you'll see deficiency of both, but sucrose is the most common of the sugars that we see. But really the prevalence of sucrase and isomaltase deficiency is not really well known. We know that there's a primary deficiency that's inherited as autosomal recessive. This is called a CSID. The estimates have been somewhere between 0.05 and 0.2%, but some groups, such as those indigenous to Greenland, Alaska, and Canada, up to 10% of people can have these genes. But there's probably a more common cause, which is secondary deficiency of sucrase isomaltase deficiency, or SID. This really has not been well studied. There was one small study in patients with undergoing EGD for chronic diarrhea and pain, and interesting, 35% of those patients had a decrease in the enzyme, sucrase isomaltase enzyme, suggesting that perhaps, in some patients with chronic symptoms, this may be more common than we think. And then there have been 2 other studies that have looked at the prevalence of CSID, of the gene itself, and you can see in IBS, in one study, 2.1% versus 1.2% of controls, and the second study, 4% of IBS versus 2.8% of control. Both studies, again, suggesting there might be higher in IBS. On the right-hand side is really interesting gene study that looked at stool frequency in a group of IBS patients, and those patients that highest risk, albeit the number being small, n equals 2, that had the This is the most active of the gene to be abnormal. You can see a much higher rate of stool frequency. And finally, in a study from Bill Chase modified NICE diet, that patients that were carriers of the CSID gene had a lower effect response rate to the low FODMAP diet. So if you look on the right hand on the graph, you can see if you did not have the gene, you was 60% had symptom relief. If you had the gene, only 43%. So intriguing data suggesting maybe this is more common than we really think. So this leads up to the current study presented at DDW, again from Bill Che's group. And then they're trying to find out the prevalence of SID in IBS-D patients. And as you can see, the population that they had, this is an ongoing study that did, and what they basically, the bottom line was that they found that SID was present in about 9% of adults with IBS-D or functional diarrhea. And when they looked at whether they were positive or negative, the type of symptoms other than bloating did not seem to be significantly different. So this is an interesting area. You're going to see a lot more data on it. It's something that we are starting to think about more because it actually may be a potentially more common in people with IBS. And of course, we know that it's easily treated with a diet. Now there's actually an enzyme replacement as well. This is another intriguing area. This is from Ali and Mark's group at Cedars-Sinai, and they really have come up with a new way of measuring hydrogen sulfide. So we all know we measure hydrogen, methane. These are currently measured breath testing, and now they're introducing hydrogen sulfide. In this study of patients that underwent breath testing, you can see most of them had IBS. They all set healthy controls, that they found using logistic regression that a cutoff of about 5 on the hydrogen sulfide could differentiate IBS-D from healthy as well as IBS-D from IBS-C. Now, only a small percentage of patients in their group, that 10% or so were positive for hydrogen sulfide, so it's not as common as you may see for methane or other or hydrogen. But again, we may be missing this in some of our patients, and they were able to show that that patients that had diarrhea were more likely to have a higher rate. And shown on the right-hand side is some of the associations between symptoms and having a positive hydrogen sulfide result. And I just highlight diarrhea as being one of the more common symptoms that be associated with, but certainly helping to differentiate between diarrhea and constipation. So this is intriguing. It's a new area. And it may be helpful in some patients, and it's not widely available, but you can get it through Gemelli Biotech, which as I listed as a conflict with me, so just an FYI. This is a study from my group that looked at predictors in healthcare use, and I just want to highlight an important point. We looked at among our patients Israel Deaconess, and what we found was that the predictors for healthcare utilization was the presence of abdominal pain and severity of abdominal pain, but also the presence of depression. It was really interesting. Not anxiety, but depression was a predictor of healthcare utilization, and poor sleep. So those, again, things that are really important. Shown on the upper right, you can see that patients had more severe pain, which is on the far right, based on the PROMIS scale, had a significantly higher rate of ED visits. Well, not surprising, but things that we have to think about in our patients. I also want to just talk briefly about a relatively new area, which is very intriguing and you should be aware of, and this is the role of eosinophils in functional bowel disease. And we all know that the association with eosinophils in mast cells may be causing symptoms in IBS as well as other types of GI disorders. The symptoms, though, that are associated with eosinophilic gastritis or duodenitis are really nonspecific, and they have symptoms that are similar to functional bowel disease. There's not been well-described definitions of eosinophilia. The most commonly used one is more than 30 EOs per high-powered field and at least 5 high-powered fields. I'll just tell you that our pathologists never do that, and we almost never see that as a finding in our patients. But look at this data that was presented by Nick Talley. This took a group of patients. This was a multi-center trial, 405 patients with chronic functional GI symptoms. They had pain, nausea, vomiting, diarrhea, bloating, early satiety, so both upper as well as lower. Most of these people are diagnosed with dyspepsia or IBS. They also had a small group of controls. They took the extensive biopsies, used standard definitions, had a single pathologist that was also reread, those expert pathologists, and counted the eosinophils. And what was most intriguing here was that 45% of these patients met the criteria for eosinophilic gastritis or duodenitis versus 6% of the asymptomatic control. So this suggests that perhaps eosinophilic gastritis and duodenitis may be more common than previously thought. Why is this important? Well, there are a number of treatments that are either in development or available targeting the EOs or mast cells, and I highlight the anti-Siglec 8, some of the drug that we've been working on, doing some of the trials, and this is the Enigma trial presented in the New England Journal of Medicine recently, using this monoclonal antibody in patients with eosinophilic gastritis or duodenitis, and you can see from the graph that it does improve symptoms. So really, this may be a game changer for the future. Of course, more data is going to be needed before we can proceed. Anyway, thank you so much for your attention, and I hope you've enjoyed this overview.